Okay, dear doctors, so in this video we shall be reading about osteoporosis. Osteoporosis. Now, this happens to be both qualitative as well as quantitative defect of bone. Quantitative defect of bone. Now, when I say qualitative, that means the bone has got low density. When I say quantitative, that means the bone has got low volume. Bone has got low volume. Remember the topic which we studied in the previous video. What was that topic? Osteomalacia. Now what happens in osteomalacia? In osteomalacia, dear doctors, the bone density is low. In osteomalacia, bone density is low, but the bone volume is normal. Bone volume is normal. But here, bone density as well as the bone volume both are low, right? That's why it is said to be both qualitative as well as quantitative defect of bone. Let's understand it with the help of some images. You see the first image. So you see the normal bone is made up of bone matrix. You see the proteins and the collagen. That makes around 35% of the bone. Whereas the mineral part, the hydroxyapatite, calcium carbonate, calcium phosphate, that makes up 65% of the bone. Now, what you see in osteomalacia, you see there is lack of mineralization, but the volume remains normal. Volume remains the same. So you see here the mineral part is low. Now what you see in osteoporosis, you see that the volume is decreased. Fine. And the overall mineral is also low. Overall mineral is also low. Mineral content of the bone overall is very low. Right? Okay. So both of them, they decrease. Bone density is also low. Let us understand it with the help of another image. You see this one is normal. Good volume, good density. This is the bone of osteoporosis. Low volume, low density. Right? Now we shall be seeing the type of osteoporosis. Osteoporosis types. First is primary osteoporosis. Primary osteoporosis. That means there is no other disease. No other disease or no other drug which is responsible for osteoporosis. So osteoporosis is probably the only disease which your patient is having. Now it is of two types. First is type 1. Now that is said to be post-menopausal. Now every female who is menstruating today, at some point of time in her life, she will develop menopause. Now, as a consequence of menopause, the hormone levels, they will decline rapidly and she will develop osteoporosis. There is no other disease which is specifically causing osteoporosis. The only thing which is causing osteoporosis is menopause, and that's a normal physiological phenomenon. Sorry. Okay, so the other type of primary osteoporosis is type 2. Now, that is said to be senile osteoporosis. Senile osteoporosis. Anyone who is young today, someday he or she will turn old, and he or she will develop osteoporosis because of advanced age. So that is why this type of osteoporosis is said to be most common type of osteoporosis. Then buddies, we have got secondary osteoporosis. Secondary osteoporosis. That means some other disease or drug is causing osteoporosis. So here the most common cause is steroid intake. Your patient is on long-term steroids, maybe because of inflammatory bowel disease, because of asthma, because of rheumatoid arthritis. So these patients will develop osteoporosis. Then there are some diseases like rheumatoid arthritis. Then there are diseases like tuberculosis. Then there are some diseases like ankylosing spondylitis. So at some point of time in the cycle of disease, the patients will have osteoporosis. So there buddies, this will be the primary disease, and osteoporosis will be the secondary disease which your patient is suffering from. So that is the difference between primary osteoporosis and secondary osteoporosis. When we speak about the clinical features, see, your patient has got weak bones and the spine is not able to support the load of body, right? So your patient again will have polyarthralgia, polymyalgia. If they ask you what is the most common clinical feature, so that will be low backache. Again, your patient will develop this clinical feature, Dovagger hump deformity. This is the Dovagger hump. This might come as an image based question, Dovagger hump deformity. Let's write it here. Dovagger hump deformity, right? Again, you see the next important clinical feature is pathological fractures. So they are those fractures which occur in a bone which is made weak by a disease. So pathological fracture, what is the general definition? So definition is fractures which occur in a bone which is made weak by a disease, right? Now here the fracture which occur in osteoporosis, they are called as fragility fractures. fragility fracture. Any patient who has got osteoporosis and develops a fracture, that will be pathological fracture because the bone is made weak by osteoporosis. And those fractures, they are referred to by a common name, fragility fractures. Fragility fractures. So there, buddies, the most common site of these fractures is dorso-lumbar spine, and then they are common at the neck of femur and also at distal radius, also called as Colles fracture, right? Now let's see what do we get to see on X-ray. What do we get to see on X-ray? So on X-ray we get to see codfish appearance, also called as fish mouth vertebra. Fish mouth vertebra. Can you allow me to zoom this image? Now see, dear doctors, if the normal vertebra is like this, let's say this is the normal vertebra. The vertebra in osteoporosis is like this. Okay, so that is the vertebra in osteoporosis. Now let's draw this here. Suppose that's one vertebra. Next vertebra would also be of the same shape and size. Here it would also be like this. Now this structure which is formed here, this is very similar to the mouth of fish, very similar to the mouth of fish. So this is called as fish mouth vertebra. Fish mouth vertebra. When we see the entire vertebral column is very similar to cod fish. So that is called as cod fish vertebra, right? You see here, when we look at the entire vertebral column, it appears similar to cod fish. So you can remember it like this, fish mouth vertebra or cod fish vertebra, both are same. See here, so the space between the two vertebra appears similar to mouth of fish, fish mouth vertebra, right? So you have to appear for NEET PG also. Must remember that cod fish vertebra, or whatever you want to call it, like you want to call it codfish, perfectly okay. You want to call it fish mouth, that is also okay. Now apart from this, apart from osteoporosis, it is seen in multiple other conditions. Now you see, there are many things which you might not be able to remember because you know there are a lot of things to study. So just remember these two. These two are very, very important. That codfish vertebra, they are seen in osteoporosis as well as in spherocytosis. Now the other thing, you see, sickle cell disease. If you can remember this one, that is also very good. Sickle cell disease. You know it, osteoporosis. Now these two you must remember, please, on my request. The other thing, like homocystinuria, renal osteodystrophy, osteogenesis imperfecta, if you have got some time to remember them, do remember them, otherwise not so important. But these three things, please Do remember, codfish vertebra. Now, what is the problem with X-ray being used as diagnostic investigation for osteoporosis? The problem is that X-ray changes are seen only when 30 to 40% of bone mass is lost. What does that mean? You see, the child is born, the weight is around 2.5 kgs. That same child will grow on to become a toddler, to become a teen, to become a young adult. His bone size and weight will keep on increasing. Till what time the bone size and mass increases? So you see, peak bone mass is seen around 25 to 30 years of age. So thereafter the bone mass, it declines at the rate of 0.5% every year. So we need some better investigation, because you see, when 30 to 40% of the bone mass is lost, then we will get to see codfish vertebra, fish mouth vertebra. But this bone is very prone to fracture. So we need to have some better investigation. And if they ask you this question, what is the gold standard investigation? What is the gold standard investigation? So gold standard investigation, it happens to be DEXA scan. What is that? Dual energy X-ray absorptiometry. Dual energy X-ray absorptiometry, that is called as DEXA scan. And what do we measure? We measure bone mineral density, primarily at two places, hip and dorsolumbar spine, right? So we measure the bone mineral density in the DEXA scan. So this is very important question. What is the gold standard investigation for osteoporosis? Now, here you see we have got to rely on two comparative scores. So the first thing is T-score. How do we get T-score? So T-score is obtained when the bone mineral density, of your patient is compared with race and gender matched younger individual. For example, when you compare the bone mineral density of a 65-year-old Indian male with the bone mineral density of a 25-year-old Indian male, so race should be same, Indian, gender should be same, male. In that case you will get T score. right? T-score. Now, for example, the bone mineral density of your patient who is 65 years of age, let's say it comes out to be X by 4 units. But the bone mineral density of young male who has got same race, fine, it comes out to be X units. Now in that case, the T-score of your patient is -4, because you see that bone density of your patient is 4 times lesser than a young male. Fine. So T-score will be -4. Now if the T-score is between -2.5 to -4, that means your patient has got osteoporosis. So the rough meaning of this term is that if the bone mineral density is 2.5 to 4 times lesser than a young male, then your patient is having osteoporosis. Please be informed that if you are testing a female, let's say your patient this time is 65-year-old female, then you should compare her bone mineral density with a 25-year-old female. So compare the bone mineral density of male with male and female with female, T-score. Whereas Z-score, the Z-score is obtained. Z-score is obtained when the bone mineral density, of your patient is compared with race, gender and age matched individual. For example, let's say BMD, bone mineral density of a 25-year-old young male. Suppose it is X units, right? Now, bone mineral density of patient X, who happens to be 65 years old Indian male, that happens to be X by 2 units. Okay. Second, bone mineral density of another patient called patient Y, who again happens to be 65 years old Indian male, that happens to be X by 4 units. Okay, so you see, buddies, their age is same, their race is same, and their gender is same. So Z-score, it just tells us which patient is losing bone mass more rapidly. Which patient is losing bone mass more rapidly? That you will get to know by Z-score, right? So prime importance is that of T-score. So T-score -1 to +1 is considered normal. If your patient has got T-score between -1 to -2.5, we say that your patient has got osteopenia. That means slightly decreased bone density. And if the t-score is between -2.5 to -4, we say that your patient has got osteoporosis, right? Now the treatment should be started. When we speak about the treatment, we have got multiple treatment options. First are the drugs which decrease osteoclast activity, For example, here we have got bisphosphonates, several types. For example, we have got alendronate, risperidone. Now they are supposed to be had once a week. Then we have got ibandronate. Ibandronate is to be had once a month. Then we have got zoledronic acid. Now this drug is to be had once a year, just once a year, right? Okay, apart from that, we can give our patient estrogen as a part of hormone replacement therapy. Another option which we have is to give our patients selective estrogen receptor modulator. Selective estrogen receptor modulators. You see these drugs, tamoxifen, raloxifen. Now why do we use the word selective? Because when these drugs, they reach the breast tissue, they stop the growth of breast tissue. That is why they are useful in the treatment of cancers. They are used in the treatment of benign conditions, right? Benign conditions of the breast like fibroadenosis. But when these drugs, they reach the bone and endometrium, they promote the growth. They promote the growth of these tissues. So that is why they can be useful, because they will promote the growth of bone, right? Then the other drug which we can use is calcitonin. You see, the action of calcitonin is practically opposite to the action of parathyroid hormone. Parathyroid hormone will promote bone resorption, whereas calcitonin will reverse that process of bone resorption, right? Then the next drug in this category happens to be denosumab. Now remember, denosumab is a monoclonal activity. Is a monoclonal antibody. I'm really sorry. Monoclonal antibody against rank ligand. So this stops the activity of osteoclast. Then, dear doctors, we have got drugs which increase the osteoblast activity. Drugs which increase the osteoblast activity. Fine. So here, you must remember that parathyroid hormone, when it is given at high doses, when it is present in high quantities in the body, it will cause bone resorption. But when it is present at low doses, it will cause the buildup of bone. It will cause bone formation, right? So here what do we use? We use a drug called teriparatide. So what is teriparatide? Teriparatide is synthetic analog of parathyroid hormone. Parathyroid hormone. So remember, let's call this PTH. So PTH at high doses, it will cause bone resorption. But if it is given at low dose, it will cause bone formation, right? So we will give PTH at low dose, so naturally there will be more bone formation. Then buddies, we have got dual action drugs. The drugs which act both on osteoclast. They tell the osteoclast not to destroy more bone, and they also act on osteoblast. They will cause more bone formation, right? So what is that drug? That drug is strontium ranelate, but it is not widely used because it has got a prominent side effect that it is nephrotoxic. So it is not widely used, right? Then you see what is the surgical treatment. At times, you know, what may happen is that the bone may be so weak that fracture may be imminent, like it might happen any movement. So in that case, the surgical treatment happens to be vertebroplasty. So the word vertebro means it is related to vertebra, and plasty means to change the shape. How do we do that? So we do that by injecting bone cement. Don't be misled. The word is cement, but it is actually a liquid. What is the formula? Polymethyl methacrylate acetate. You see here, the vertebra has become very weak and low in volume. When you inject the bone cement, the shape of vertebra becomes normal and the vertebra becomes strong enough to take the load of body, right? Okay, so that was all about this important disorder, osteoporosis. Thank you so much.